Okay, this is part two for my NP students. If your patient has a cough for more than 5 days, one of your differential diagnoses should include pertussis. Remember, this is bacterial infection, very contagious. Think of pertussis with whooping cough. Sign symptoms you may see described in the question for it: fever, rhinorrhea, and of course, whooping cough. You get something about an elderly patient on inhaled steroids for years. What are they at risk for? Osteoporosis. Screening for TB, Mantoux test, if positive, chest x ray. Notice I said screening. Both of them are screening tests. Remember, the only definitive diagnostic is what? Culture, okay? Okay. Your sputum, spirit, your culture. The head of infants and children up to 18 months is okay. The head of infant and children up to 18 months is commonly 1 to 2 centimeters larger than the chest circumference. So if you get a question about a child at 18 months or younger and they ask you what is expected diameter size, they give you the chest. This is what you need to know. Again, the head of infants and children up to 18 months is commonly 1 to 2 centimeters larger than the chest circumference. So that's how you figure that out. Make sure you know about the etiology for cough. When it comes to bronchitis, it's usually viral. You are not going to order antibiotics, okay? Make sure you know the common etiologies, what can cause the cough. Asthma, GERD, infection, ACE inhibitors. Usually, well, I'm not going to say usually, but the chances are high they'll be let me not even say that. Moving on. Anyway, when it comes to ACE inhibitors, because ACE inhibitors can give a cough. If you can't remember any of your ACE inhibitors, please remember Ramipril. Okay. Acute bronchitis, again, usually it's a viral infection. You're not going to give antibiotics for it. I said that 2 or 3 times already. I did that on purpose. Okay, moving on. Let's move on to pneumonia, chest x-ray, dullness to percussion. What you'll see on the chest x-ray, let me back up. What you'll see on the chest x-ray, consolidation. You see consolidation, you should think pneumonia, okay? But upon auscultation, dullness to percussion. Definitive diagnostic test of pneumonia. You're going to do the chest x-ray. You may see consolidation. You may see infiltrates. You see that? You need to be thinking pneumonia. Strep pneumonia, that's the most common cause of pneumonia in patients of all ages. You need to know that. When it comes to strep pneumonia, in the question, they'll give you those clinical manifestations of pneumonia. But one thing that you'll see mentioned is rust-colored sputum. When you see that, you need to be thinking of strep pneumonia. Mycoplasma pneumonia, that's your walking pneumonia. You need to know that. If you suspect your patient with pneumonia has drug-resistant pneumonia, okay? Let me not say that. That's going to get me in trouble. I'm going to move on. How about this? I'll say this to you. Look up. Make sure you know drug-resistant pneumonia. Make sure you know those clinical manifestations and the diagnostic test and what you would order. Make sure you know the pneumococcal vaccine, your PPSV23 versus your PCV13, and your PPSV23. By the way, if you're having any issues with that, I have both a lecture and a Q&A that I did on that, so just check for it on my YouTube channel. COPD. For COPD, you need to know that there's airflow limitation. It's progressive, which means as time goes on, it only gets worse. Patient has inflammatory response. You need to know how to calculate pack year history. And you need to know it's irreversible. So you know how asthma is reversible. You give the patient a SABA and it should reverse that airflow limitation. Not so much with your chronic bronchitis or your emphysema. As time goes on, it only gets worse. It's progressive. You need to know that. You need to know the link between tobacco and COPD. And when I say tobacco, that includes secondhand smoke. You need to know how to diagnose COPD, and I'm talking about the reaction after bronchodilator, FEV1, FVC ratio, the pulmonary function test. You need to know the GOLD staging system for your COPD. You need to know the comorbidities with COPD, especially anxiety, depression. You need to know about COPD and beta blockers. Do not give a beta blocker to a COPD patient. Stay away from those drugs that end in LOL. Stay away from the leukotriene blockers as well. Stay away from codeine. You're going to give that very cautiously to a patient with COPD. Make sure you know your bronchodilators. Make sure you know which drug stimulates the lungs. Which drugs help with COPD but can cause AFib and aflutter. Action of ipratropium. Did I mention that? Make sure you know how to prescribe for COPD. So first, you're going to give the patient a anticholinergic as needed or SAB, and then go down the line. Make sure you know that. Make sure you know the management for exacerbations. Know when to add anticholinergics if the short-acting bronchoagonist is not working. For asthma, make sure that you know that, again, it's reversible. That's one of your biggest differences between your asthma and your COPD. Make sure you know what asthma looks like in the older adult, like the geriatric population versus your normal, otherwise healthy adult. Make sure you know that fever is not typical of asthma. Make sure you know your stepwise approach in prescribing for the patient with asthma. Make sure you know these drugs, the steroids versus make sure you know albuterol, leukotriene blockers such as Singulair. Make sure you know your LABAs versus your SABAs. Oh, I'm running out of time. Make sure you know osteoporosis, its effects, and what you're going to order.